Thank you, Ted, for that introduction, and thank you for making time to come to this grand rounds. I'm hoping that when you leave here, you'll feel inspired by the changes that have happened in asthma care, and perhaps you'll find some patients in your clinic that you think we could help. So I'm willing to take any and all questions at the end of the talk. These are my disclosures. I do a fair number of clinical trials in asthma. The companies are listed here. I've also served on several advisory boards. The patient I'm presenting today is 71 years old, has asthma that was diagnosed 4 years ago, so adult onset asthma. Presented initially with recurrent sinusitis, cough, shortness of breath, and wheezing. Over these past 4 years, this patient has suffered with multiple exacerbations requiring steroids and antibiotics, 1 emergency room visit, no hospitalizations or intubations, has had allergy testing and is on immunotherapy, continues to have a very significant burden of disease with daily symptoms, chest tightness, shortness of breath, and frequent exacerbations. So he has obstructive sleep apnea, is compliant with that, bronchiectasis, GERD, which is well controlled, some other comorbid conditions, and chronic sinusitis. Of importance, this patient had sinus surgery in January 2016 and was found to have eosinophilic sinusitis. The patient is on high-dose ICS-LABA, nasal spray, Singulair, and Ventolin, and like most severe asthma patients, uses Ventolin multiple times per day. I'm sure you've encountered some of those patients in your clinical practice that ask you for 2 Ventolin inhalers a month because 1 isn't enough. So the patient is married, a retired ICU nurse, a lifelong non-smoker, had some imaging within the last year and a half that showed mild lower bronchiectasis and diffuse mild air trapping. It's really important to remember that almost every severe refractory asthma patient has demonstrated mild lower lobe bronchiectasis. So don't get too distracted when you see a little bit of bronchiectasis. It's a consequence of severe disease. If it's fairly diffuse and quite significant, then it's a different issue. This patient has peripheral eosinophilia, 900 cells per microliter, an IgE of 62, other labs are normal, positive skin tests, and a negative ANCA. The pulmonary function tests here are fairly normal, except for small airways disease, which you can see here with a decreased FEF 75-25, right there, of 63% predicted. And so the normal FVC argues against restriction or air trapping, but we don't have full pulmonary function tests. So what is asthma? This definition of asthma is from 2007, which is the last time that the NAAPP guidelines were updated. And they described asthma as a chronic disease characterized by recurrent episodes of symptoms related to lung disease, which is wheezing, shortness of breath, and cough due to quote-unquote reversible airflow obstruction. Also, you should have bronchial hyperresponsiveness and some kind of airway inflammation as the hallmarks of asthma. And up until the last 5 or 6 years, we thought that inflammation always had to be driven by eosinophils or allergies. So even in a very mild asthmatic here, you can see demonstrated characteristics of the disease. The airway epithelium is denuded. You don't see cilia. You have mucus gland hypertrophy. The basement membrane is thickened, and there are inflammatory cells in the mesenchyme. And these changes are far more exaggerated in patients with moderate and severe asthma. In terms of classifying severity of asthma, you have to note that these classifications were based on patients not on any therapy at the initial diagnosis, which fortunately or unfortunately is not often the scenario, particularly in a subspecialty area where patients come to you already on treatment. And so the severe patients suffer a significant burden of disease. They have a lot of symptoms. They wake up at night. They use their beta agonist frequently. They have extremely limited activity, and they will have some limitations in lung function. And I will tell you and on the next slide why you shouldn't get too hung up on the airflow limitation, because I think that's a frequent error that people make. They say your lung function is normal, so you should be fine. These patients also have a significant amount of exacerbations. So in 2014, the ATS and ERS came together and redefined the definition for severe asthma. And I want you to note that there is no reference here to lung function impairment. So if a patient has normal lung function but requires high-dose ICS LABA and a third controller or oral corticosteroids more than 50% of the prior year, they meet the criteria for severe asthma. So if you require quite a significant amount of medications to maintain control, you meet the criteria for severe asthma. The other commonly made mistake is that you find a patient that has severe asthma, you adjust therapy, or you initiate targeted therapies. They get better, and then you decide, you reclassify them as mild asthma. That's not the right nomenclature. That patient would still be considered a severe asthmatic, except now they would be well controlled rather than uncontrolled. And so you can see what defines poor control here. Some kind of questionnaire score that shows poor control. Frequent exacerbations, the threshold is not that high, 2 per year. 1 hospitalization, ICU stay or mechanical ventilation, and some lung function impairment defines poor control. And so what we've moved to in asthma care is not to focus entirely on severity, because we now know that severity is a property of the disease. And although we are extremely good providers, we have very little influence over whether somebody has mild or severe disease. That's inherently a property of their disease. On the other hand, control reflects the adequacy of treatment, and where we need to focus all our efforts is in improving asthma control. So all of us in the room here have a significant role to play in ensuring that patients have excellent asthma control. And the GINA guidelines here, I reference these rather than the NAPP because it hasn't been updated since 2007. The GINA guidelines are updated yearly, and you can see here that the severe patients fall in the step 4 to 5 therapy. So they're going to be on medium high-dose ICS LABA plus tiotropium, plus if you're step 5 patients, you're going to be on some kind of biologic, either anti-IgE, anti-IL-5, or daily low-dose oral corticosteroids. And when you're managing patients with severe asthma, you're basically reviewing the risk. You're starting out with an assessment. You're trying to figure out what's the level of control. Is the person using their inhalers properly? Are they adherent? And what therapies do they prefer? You're then adjusting their medications, and you're introducing some non-pharmacological strategies. For example, targeting vocal cord dysfunction or obesity-related issues, GERD, and other comorbidities. So you're treating those modifiable risk factors by adjusting treatment. You're then bringing them back, and in a systematic manner, you're looking at symptoms, exacerbations, side effects, patient satisfaction, and lung function. And based on your success or failure in terms of achieving optimized care and control, you're then resuming this circular pattern of assessing, adjusting, and reviewing. Now, you always have to think about comorbidities when you're dealing with asthma. These are just but a list of the ones, and so you need to be assessing whether patients have any of these contributing factors and treating those appropriately. So this patient continued to have exacerbations, was basically on multiple courses of oral corticosteroids, would maybe have a 3 or 4 week respite from oral corticosteroids before needing additional steroids. She had an elevated fraction of exhaled nitric oxide of 132 parts per billion. This is used as a biomarker for type 2 or eosinophilic inflammation, mainly type 2 inflammation. She had a methacholine challenge test, then underwent a bronchoscopy, and was found to have tracheobronchomalacia, another often found comorbidity, particularly in people who have very severe cough. And she had mucus plugging, grew Klebsiella, was treated for that, had a differential cell count of 37% eosinophils. A couple of things to note about methacholine challenge testing. So basically, when you bring a patient in for methacholine challenge testing, they have to withhold medications based on the half-life of the inhaled medications. They have to withhold them between 48 and 72 hours, sometimes a week if it's a long-acting antimuscarinic drug. The patient comes in, they perform baseline spirometry, and then they receive methacholine. So they nebulize initially very dilute fractions of methacholine, and then you increase the amount of methacholine concentration. And what you're looking for is a PC20, which is basically the dose, the concentration or dose at which the patient loses 20% of their baseline lung function. What you need to remember about methacholine, though, is that it does not rule out asthma. And it has a very high negative predictive value. So if you believe that this patient has asthma, I think she has a 70 or 80% probability of having asthma based on her workup so far, her elevated FeNO, eosinophils, relatively normal chest CT scan, sinuses with eosinophils, and symptoms that respond to treatment with steroids. So if you assume she has a 70 or 80% pretest probability of asthma, a negative methacholine doesn't quite do very much to rule out asthma. You might end up with a post-test probability of 40 or 50%. And so you should use methacholine testing only if there's an atypical finding or some other suggestion that perhaps this isn't asthma and you're trying to exclude the diagnosis. But if you have a high clinical suspicion for asthma, the methacholine doesn't really change your diagnosis. You should use caution with FEV1s less than 50% of baseline. So this patient continued to receive a lot of oral corticosteroids, which tends to be one of the go-to drugs that we use in severe asthma. I mean, I think a lot of people have a lot of familiarity with oral corticosteroids. They work, they're cheap, and so we give oral steroids when patients are having poorly controlled asthma. Oral steroids have broad mechanism of action. They are natural steroid hormone. They are synthetic analogs of natural steroid hormones. They mediate their effects through the glucocorticoid receptor, which is widely expressed throughout the body. And after binding the receptor, the glucocorticoids induce or repress the transcription of multiple target genes, which comprise between 10 and 20% of the human genome, which means that your oral steroids are affecting multiple different pathways, and that causes significant negative consequences. So you're treating asthma, and I'm going to review some data on how oral corticosteroids may have adverse effects in patients. The cellular response is diverse, both in specificity and sensitivity. In asthma, oral corticosteroids are quite potent killers of eosinophils. They induce spontaneous cell death. I'm sure you've taken care of patients in the hospital who get a dose of Solumedro and have 0 eosinophils. Then they also cause macrophage clearance of apoptotic eosinophils. They affect T cell production of various cytokines and inhibit survival factors. They also have effects on fibroblasts and epithelial cells. So again, fairly diffuse effects on various cell lines in asthma. And so, as you might imagine, unfortunately, OCS use is quite wide here in the U.S. 3 million patients with asthma in the U.S. get more than 2 OCS prescriptions per year. And you can see on this map where we are in the 85th to 100th percentile ranking of county prescriptions for patients getting greater than 2 OCS prescriptions per year. So why does that actually matter? 2 doesn't seem that bad. But there is a higher risk of comorbidities in OCS-treated patients with severe asthma. And here you can see that patients with asthma receiving regular doses of OCS have higher risks of multiple comorbidities. Perhaps glaucoma is the only thing that crosses the interval there, but in general, you have a higher risk of developing multiple comorbidities, none of which is very cheap to treat. And so although we may think the purchasing of the drug from the pharmacy is quite cheap, all of these negative consequences result in treatments, hospitalizations, and other healthcare-related costs. So there is actually a dose response with regards to negative consequences of OCS. And you can see here that the highest dose is, so they have 3 categories. They have greater than 12 milligrams, 6 to 12, and less than 6. So if you're getting less than 6 milligrams, your risk is not significantly impacted. However, the higher the dose of steroids, in general, the higher the risk of developing multiple systemic comorbidities. So now we are going to have a poll for the audience here. I would like a show of hands for each of these choices that I'm going to read out. So how many courses of oral corticosteroids are safe over a lifetime? We're talking about a lifetime, not a year. So 0 to 1. How many are in the 0 to 1 category? Okay. 2, 5. Anybody in the 5? A few people in 5. 10. How many are in the 20? I guess everybody else 20? More than 20? Okay, some people chose not to vote, so I'm going to assume 10 was the most popular answer. And so this is a study that's unpublished data, thanks to Dr. David Price in the UK. And they wanted to answer the question, how much steroid is too much steroid? And so they took patients with asthma, they put them in an observational study prior to any incident use of oral corticosteroids, and they tracked them in a database looking longitudinally. They had quite a large cohort, followed them for many years with a median follow-up of between 6 and 7 years. And so the SCS arm, those are systemic corticosteroids, it could be oral or IV, greater than 1 prescription within 18 months. And then these folks never had oral corticosteroid or systemic corticosteroid exposure. Now, remember that 1 gram of systemic corticosteroids is equivalent to 4 short courses of OCS at the usual doses for treating an asthma exacerbation. I think most of us will admit that we've prescribed to one patient more than 4 courses of steroids. So when they followed these patients, I think that you would be shocked to realize that between the threshold at which you start to see an increased odds of negative adverse outcomes is 1 to 2.5 grams. So within this 8-year period of time, if you had more than 4 courses of oral corticosteroids, you started to see negative consequences, which is this green bar right here. So you can see you have a higher risk of cerebrovascular disease, heart failure, MI, cardiocerebrovascular diseases, diabetes, glaucoma, osteoporosis, sleep apnea, depression, perhaps not peptic ulcer disease, but 4 courses of oral corticosteroids. And so I want you to reflect on how many patients you have given more than 4 courses of oral corticosteroids in the last year, 6 months, 3 months. And this, and patients come into the hospital, they get very, very high doses of systemic corticosteroids. So what do we think asthma is now? Now we believe that asthma is a complex disorder that has many distinct pathophysiologic mechanisms contributing to clinical signs and symptoms. And we now know that the pathology of asthma goes far and beyond eosinophils. So we think that T cells are involved, they secrete IL-5, B cells are involved, they secrete IgE. We have multiple cytokines such as IL-4 and 13 that are produced by T cells that cause mucus hypersecretion and inflammation. Also, we know that there are non-type 2 asthma. These are the patients who have asthma driven by neutrophils, interferon gamma, TGF-beta, that cause downstream consequences such as bigger blood vessels, more airway edema, smooth muscle hypertrophy, and inflammation. And so now we talk about phenotypes. And those phenotypes are the observable properties of an organism that are produced by the interaction of genotype and environment. And an endotype is supposed to be connecting the symptoms, signs, and lung function measurements you see to some pathologic mechanism. And so this is what we mean by phenotypes. You see a patient who has adult onset asthma. That's a clinical phenotype. People who are obese, people who have high eosinophils, people who have aspirin-induced asthma, or exercise-induced asthma. Those are all phenotypes. Phenotypes suggest a clustering of characteristics, but may not be necessarily tied to any particular mechanism. So we've learned a lot about asthma phenotypes from various asthma cohorts. This is the Severe Asthma Research Program, and they used hierarchical clustering of multiple different factors to see if they could find certain groups of patients that have similar characteristics. So as an example, you can see here, these are the fixed airflow obstruction. So remember, initially I said asthma was a reversible disease. You had reversible airflow obstruction, but here you have patients who have severe fixed airflow obstruction. They are older, they've had asthma for a really long time, they are not atopic, they have very low FEV1 with COPD similarities, they have a high frequency of symptoms and albuterol use and oral corticosteroids. On the other hand, you might have these folks over here who have relatively preserved lung function. They are obese as well. They have some reversibility, not complete. They have very, very many symptoms and continue to have sputum eosinophilia. So again, you see that lung function isn't the be-all and end-all in defining severe asthma. There are also patients who have milder disease, but these three clusters here are severe asthma clusters with differing presentations and differing levels of sputum eosinophilia and neutrophilia. And so just to further define what we mean is that if you have the asthma syndrome, what we used to say is asthma, you're going to have symptoms. You'll wheeze, you'll cough, you'll have a low FEV1 perhaps, you'll have exacerbations, you'll have inflammation, you'll have atopy. And then we're going to look at your phenotypic characteristics. So age of onset, are you allergic? Are you eosinophilic? Are you obese? Do you have no inflammation? And then we're going to talk about your endotypes, where we are now looking at what the mechanism is that may be driving the presentation that we are seeing. And so, for example, you have the early onset allergic type 2 high IL-4, IL-13 patients, the late onset IL-5 patients, the mast cell associated exercise-induced asthma patients, and so forth. The reason this matters is that there are now biologic targets in asthma. In many ways, the rheumatologists are far, far ahead of us. We're trying to catch up by producing quite a few biologic therapies for patients with asthma. So what they've done is looked at airway expression of different markers. And so here we have TSLP, thymocyte lymphocyte protein, and TSLP is now a target of therapy. There are phase 3 studies looking at that. We have targets for IL-13. Many of them have been negative so far in phase 3 studies. We have the IL-4 receptor alpha antibodies, dupilumab, which may be approved later this year. And so now we have IL-5. We target IL-5, or we directly target the eosinophil with IL-5 receptor antibodies. So what we are trying to do is not just give every single person inhaled and oral corticosteroids, but to sort of get at what might be driving your disease via surrogate markers, because unfortunately our biomarkers are not excellent, and then target the underlying pathophysiology. And so I will go over the biologic therapies that are approved for asthma. The first one that was approved was omalizumab, which is an anti-IgE antibody. And you can see here that omalizumab, it's given to people with allergic asthma. And you can see that in patients with omalizumab, you lose that seasonal variability in exacerbations. You have fewer symptoms, and you have less inhaled corticosteroid exposure. Importantly, you also have biomarkers that may be able to tease out which asthma patients are going to benefit from omalizumab. And here we have a post hoc analysis that showed that if your exhaled nitric oxide level is elevated above 19.5 parts per billion, you have a better reduction in exacerbations if you use omalizumab. Conversely, if your eosinophils are above 260 microliters, you may benefit from therapy with omalizumab with a 32% reduction in eosinophils. And then lastly, periostin, greater than 50, you have a 30% reduction in exacerbations. And so it's quite important to pick the right patient. Here is the data on mepolizumab, which is an anti-IL-5 antibody. Over here you can see that giving a dose of mepolizumab significantly reduces the number of eosinophils in your blood. So these are patients with high eosinophils. There is a slight improvement in lung function, about 100 mLs, and you have a significant reduction in exacerbations. And if you believe what I just told you about the negative consequences of oral corticosteroids and exacerbations in asthma, then this reduction in exacerbations is something we would want to be able to offer the right patient. Now you have to remember that mepolizumab is approved for people with eosinophilic asthma. There are effects in patients with greater than 150 eosinophils cells per microliter. However, the best results are in people with greater than 300 cells per microliter. This is benralizumab here, and you can see benralizumab significantly reduces exacerbations. These are patients with greater than 300 eosinophils. Less than 300 eosinophils, there is an impact, but not quite as significant as the greater than 300 eosinophils. You also see here on the second schema, this is lung function changed from baseline pre-bronchodilator FEV1, and you can see that benralizumab at 2 doses, they gave it at 4 weeks, and at 8 weeks, it's currently approved for 4-week dosing period 3 times, followed by every 8-week dosing, and you can see an improvement in lung function. You also have improvements in asthma control. Now, if you really believe that oral corticosteroids are toxic at even intermittent doses, then those patients that suffer the most toxicity are those that take it every day. And so we should be extremely motivated to get people off daily oral corticosteroids. And you can see here with the mepolizumab OCS weaning studies, there's a decrease in oral corticosteroid dose of about 50% during this 24-week period, and concomitantly a 32% reduction in exacerbations. So you're reducing steroids and you're reducing exacerbations. Here are the effects of benralizumab. There's about a 75% reduction in oral corticosteroid dose. Again, a concomitant reduction in exacerbations. Reslizumab, similarly, this is an IV anti-IL-5 therapy. You have a reduction in exacerbation. This is what is the probability of not having an exacerbation? It's much more significant in the reslizumab group. One thing to remember about benralizumab is that it targets the IL-5 receptor, which causes eosinophil apoptosis. So it's a different mechanism of action from the other 2 IL-5 drugs. So what happens to those people on the other end, the non-type 2, non-eosinophilic patients? Unfortunately, those patients don't have a lot of great options, and that's an area of interest in what we are studying at this point. One of the things I haven't included here is the TSLP antibody, which seems to work also in people with low eosinophils. And just to stress the importance of accurate patient selection, here you have a study with severe asthma patients looking at exacerbations. This is the proportion of patients free from the primary endpoint, which is exacerbations. You have placebo and azithro, a negative study. However, if you then go and do a subgroup analysis, which was unfortunately not an a priori hypothesis, you pull out all the patients with relatively low eosinophils, you start to see that azithromycin may be beneficial. The jury is still out on azithromycin, and as far as the ERS ATS guidelines are concerned, they do not recommend chronic use of macrolides for asthma. This is tiotropium. The forest plot here just basically shows you here we're looking at ICS versus tiotropium plus inhaled corticosteroids, and it favors the addition of tiotropium, which isn't surprising because you're adding a bronchodilator. If you have, and this is morning peak flow and evening peak flow. Here we have patients who are already on LABA plus ICS, and we are adding tiotropium as triple therapy, and you can see improvements in lung function by adding a second controller, a second bronchodilator. And then ICS tiotropium is equivalent to ICS LABA, so if you have patients who don't tolerate LABA, you can add tiotropium. This is tiotropium in severe asthma. And so basically here you have improvements in lung function, reduction in exacerbations. So if you're not using tiotropium, I think you should consider adding it to your armamentarium of drugs. There are two ways to administer tiotropium. One is in a Respimat inhaler, and one is in the HandiHaler. The Respimat inhaler is the only one that's actually been approved for asthma, and it's the 1.25 microgram dose, 2 puffs once a day. So how can you pick out patients that may respond to tiotropium? People with a bronchodilator response, people with obstruction, and interestingly, if you have higher cholinergic tone, you may benefit more from anticholinergic therapy. So lastly, bronchial thermoplasty. And so here we show a normal airway, and here we show an airway where there is smooth muscle hypertrophy, which presumably causes constriction and obstruction of airflow with associated asthma symptoms. So this is the data on bronchial thermoplasty. It was approved for use by the FDA quite a number of years ago. It has not been widely used because most insurance companies still consider bronchial thermoplasty an experimental treatment. And the reason for that is because there is a significant placebo effect in the clinical trials. So in clinical trials, they had patients who got sham treatment. They came in, they got sedated, they had the bronchoscope introduced into the airway. The device was introduced into the airway. The pedal on the device was pressed. It made a clicking sound, but it didn't deliver any thermal energy to the airway. And the primary outcome of the initial studies was quality of life, and not surprisingly, there was a placebo effect, and patients felt better whether they got the actual treatment or not, although there was a more significant improvement in those with the treatment. And so here you can see these were secondary outcomes. You see a reduction in severe exacerbations, unscheduled office visits, ER visits, and some reduction in hospitalizations. They have now produced the 5-year safety data. There was a lot of concern that reducing airway smooth muscle size would make the airways more floppy. They followed that up. There's been no evidence of bronchiectasis or bronchiomalacia. And you can see a relatively sustained effect with regards to exacerbations and severe exacerbations in patients who received bronchial thermoplasty and have been followed for 5 years. So we actually have a bronchial thermoplasty program that will be starting here at Michigan Medicine, hopefully within the next few months, with Dr. Doug Ehrenberg and our new interventional pulmonary faculty member, Dr. Pepe Cardenas. So you'll start seeing the option in my chart to refer patients specifically to be evaluated for thermoplasty. So in this particular patient, we considered him somebody with severe eosinophilic asthma. And so he was started on mepolizumab. After starting mepolizumab, the patient had near complete resolution of asthma symptoms. No exacerbations for the past year. An asthma control questionnaire score of 25. A significant reduction in inhaled corticosteroid use to 1 puff twice daily, and was actually asking whether he should continue inhaled corticosteroids at all. And an improvement in lung function, although the lung function was initially normal in the 92% range, it's now 118%, with a reduction in FeNO from 132 to 46 parts per billion. And so what I hope that I've been able to talk to you about today is that asthma therapy is changing. And in the future, I think there would be some need to talk about how we might even change how we manage mild to asthma. But today we are focused primarily on severe asthma. And so what you're doing when you meet a severe asthmatic is you're doing some baseline assessments. You're measuring lung function, you're talking to them about control, you have some questionnaires you're administering, you're assessing their symptoms, you're determining what phenotype you think the patient has, you're talking to them about exacerbations, you're assessing oral corticosteroid exposure or any systemic corticosteroid exposure, and you're managing comorbidities. And then you're determining if they're adherent. So here you confirm the diagnosis, you talk about adherence, and you follow them frequently and try to deal with any of these comorbidities that may be present. But at the same time, you're doing some phenotypic and biomarker evaluation. So you're checking to see if the patient has allergy sensitization, you're sending them to allergy perhaps for skin prick testing, or you're doing RAST testing. You're looking at total IgE, you're looking at eosinophils. You want to bear in mind that in some people, eosinophils are quite variable, particularly those with a lot of oral corticosteroid exposure. So if you measure it once and it's low, that doesn't mean that it's always low. You always want to go back and look at historical eosinophils, or at least repeat it when there hasn't been any oral steroid exposure. If you're able, you're measuring FeNO. And then you're sort of deciding if they fit in one of these 4 categories. And this is one of the recommended ways to divide the patients into groups. So you're saying you're a severe allergic phenotype. In clinic, to me, that looks like someone with hay fever and hives and allergies and seasonal variation in exacerbation and a high IgE. And so I may decide to target them with omalizumab if they're poorly controlled in spite of the various things that have been done to improve their control. Or you could say, well, I'm going to go higher up into the pathway, target the cytokines produced by T cells, and that would be using a drug called dupilumab, which is not FDA approved at this time, but we should find out in October if it's approved. It's actually currently FDA approved only for treatment of atopic dermatitis, but not asthma. And so here you have the severe eosinophilic asthma phenotype. In clinic, that's an adult onset asthmatic. They have a lot of nasal polyps, anosmia, peripheral blood eosinophils in sinus tissue. They may or may not have eosinophilic esophagitis. Sometimes they have overlapping eosinophilic diseases such as eosinophilic pneumonia, hypereosinophilic syndrome. So there's quite a large array of patients that fit this severe eosinophilic phenotype, and there may be overlapping diseases. They may also present with ABPA but have eosinophilic asthma as the baseline disease. And in this case, you have 2 options, IL-5 antibodies or IL-5 receptor antibodies. If they have severe physiologic impairments and they don't have any inflammation. This would be the person with a eosinophil count of 100, not much sinus disease, has obstruction with reversibility, a lot of cough, and mucus hypersecretion. I may lean more towards either adding a LAMA like tiotropium or bronchial thermoplasty. And then lastly, these are those neutrophilic phenotypes. These patients are often the ones where you're wondering if they have bronchiectasis. They're producing a lot of mucus, they're congested, they grow pathogens like Pseudomonas when you culture their sputum. They have a lot of inflammation, and we don't have a lot of good therapies. They are non-allergic, non-eosinophilic. And so actually, we hope to soon have a study looking at whether IL-6 is a potential target for patients in that category. And so we have an asthma program here now. I added this information from the registry, and I think it's important to note that severe asthma patients are taken care of quite frequently solely in primary care. So about 21% of patients are taken care of solely in primary care. We have about 2,000 patients that would meet the criteria for severe asthma based on their medications that are prescribed for daily use of asthma therapy. So there's a comprehensive asthma program at Domino's Farm. We have a severe asthma clinic at Northville, and we are always excited to accept any patients that may require our expertise. We also have a very robust clinical research program where we are testing new therapies such as anti-TSLP, IL-33 targets, and IL-6 targets, other kind of therapies for patients that don't quite fit the categories that are being treated at this time. So if you have a patient that meets any of these criteria, someone who's had life-threatening asthma or hospitalization, poor asthma control in spite what you feel is optimized therapy, symptoms that don't quite fit, you need more testing, definitely oral corticosteroid dependent patients, people who need immunotherapy, those stuck on step 4 or 5 therapy that remain uncontrolled, a lot of oral steroids, or you're considering some of our advanced therapies or clinical trials, we would be happy to see those patients. And so I wouldn't be able to do the work I do without my amazing team. And these are my coordinators, my admin, and my physician assistant that are all part of our asthma program. I'd be happy to take any questions. Thank you.
So thank you, Njira. Questions? Since I have the mic, I'll ask the first one.
Okay.
So I'm relatively old, and we used to have a drug called theophylline.
Yes.
Does it still exist?
Yes. So theophylline is a good option. A couple of things to think about when you're going to use theophylline. We no longer dose it by level. You dose it at a low dose, probably 200 to 300 milligrams twice a day, because it works synergistically with oral corticosteroids. So you're not looking to dose it by level for the bronchodilatory effect. You have to watch out for people who have GERD. It can make GERD worse. And at times it's hard to get because the production of theophylline is variable. There are times you prescribe it and the patient can't fill it, especially if you pick the formulary drug. But it is a good drug. I try it in a lot of patients. If you're, however, on the quite severe end, it often doesn't dramatically change your asthma. But it is worth trying theophylline, and it is included on the GINA guidelines, as is xylutone, which is a 5-LO inhibitor that you can use in patients. But I think xylutone is not that well tolerated and doesn't have a big bang for its buck, and it's $2,300 a month, which, by the way, is similar to the cost of an anti-IL-5 therapy. So you have to sort of weigh that.
Thank you so much for the talk and for coming to Michigan.
Thank you.
I'd like to understand more about the eosinophils. They're such spectacular cells.
Yes.
Are they manifestations of the inflammation, or are they in the causal pathway? A couple times you said caused by eosinophils. And I don't know how much to put on that, whether it's cells and many components, whether it's the IL-5.
Right.
Sounds like there's a lot more known than there used to be.
That is true. So I think eosinophils continue to be mysterious cells. So is it IL-5 causing eosinophilia? There are a lot of debates about is it eosinophils in tissue or eosinophils that have already been expended and are in the BAL, which eosinophils are inflammatory. Now we know that we have associative studies that show that eosinophils may be actually directly causing inflammation by producing granular proteins that are inflammatory. But we are not 100% sure that eosinophils are totally bad. We know they are good if you have parasitic infections and other kind of helminthic infections. And so it may be a surrogate marker for other inflammatory pathways. So for example, if you have high IL-4, you're going to produce more eosinophils. Maybe it's the IL-4 that's the problem. But we have very poor biomarkers. So we can't look at a patient and say, you have high IL-4 and you have high IL-5 and you have upregulation of IL-13. So we use these very downstream measures of inflammation. But that is a very good question. Now, the other question that comes up is that with benralizumab, for example, you have complete and total depletion of eosinophils within 24 hours. So then patients will say, do I need my eosinophils? And if you take them all away, is something going to happen? And at least in clinical trials, if patients don't have any of those infections, they seem to have no negative consequences. But, these drugs were only approved in the last, 6 or 8 months. But so far, the patients seem to not have any major negative consequences of having no eosinophils. So we don't know for sure how it's all going to play out over time.
Other questions?
Yeah, so I'm completely convinced that steroids are bad. I'm wondering if you can make it their chronic regimen to decrease the number of oral steroid bursts they have to get.
Mm-hmm.
I'm wondering though, all these medications obviously take a while to get approved. So I'm wondering acutely when a patient comes in and is more symptomatic, what is your threshold where you say, okay, it was worth it to give them a burst of steroids?
Right. So I have the conversation with patients all the time because they'll come in and say they'll be referred for non-oral corticosteroid dependent asthma, but when you talk to them, I took a taper for 2 weeks the last 6 months. Every 2 weeks I took a taper. I was off for 2 weeks. I got really sick. Then I took another taper starting at 60. And my discussion with those patients is that your cumulative exposure by multiple tapers is way more than just a low-dose OCS. And so I do start patients on low-dose OCS. And I engage in a conversation with them about what's the best dose for you? Because patients will always be able to tell you a threshold. They'll tell you, when I get below 20, after 3 days, I get congestion and coughing. And some of those thresholds are quite high. They're 30 and 40 milligrams a day of prednisone. And so I will start oral corticosteroids, but the plan is always to find an exit strategy. So I'm starting oral corticosteroids to get you off the hamster wheel of going to the ER and needing multiple bursts and getting Solumedrol, but the plan is to start one of these IL-5 drugs. About 30 or 40% of patients will come to the clinic and say, wow, it's like a seismic boom. They're like, you have cured me virtually almost of asthma symptoms. They have a profound response to these drugs. About another third will come back and say, I feel better. They won't be so, dramatically better. And the oral corticosteroid patients with eosinophilia usually have a wonderful response. And then about another third will say, I'm not so sure this helped me. But if you've I spent the last 10 years taking care of severe asthma patients and giving them steroids because I had no choice. It's quite a refreshing experience now to say to patients, I have an option for you, starting the drug, and within 2 months having people come back and say, I've not felt this way for 10 years. I mean, there's a lot of crying in the severe asthma clinic, some good tears, some bad tears, but I think our threshold as a community of physicians for oral steroids is a little high. We feel so comfortable with it, we overuse it, and we wait too long to refer patients for what we perceive as, newer, more expensive therapies. But once you've had that one experience, it really does change how you view these medications and these patients.
Other questions?
About the AMG 317. So is that still under trial or is it approved? What is its status?
It's still being studied.
And if you have a drug that sounds awfully expensive and it prevents a hospitalization or an ER visit, that probably covers the cost.
Right. So most of these drugs range from between $2,300 a month to $4,500 every other month. However, I think when you're doing the cost analyses, you have to think about the fact that patients who get steroids can get MIs. Sometimes people get a dose of steroids, end up in the hospital with sepsis, pneumonia. You fracture your hip, you have surgery. So we don't think of all those associated costs that are directly related to treatment. And once you start factoring in all those comorbidities that we are potentially impacting patients' lives with, it really does pay for itself. The problem is that the drugs are not disease modifying. So I can't look at a patient and say, I gave you mepolizumab or benralizumab and you're so much better, and next year we can stop it. Because when you stop these drugs, although there are studies going on now to determine can you ramp down, can you space out, can you stop, we know within 3 or 4 months the eosinophils come back. Now, whether somebody has less severe disease, I think Dr. Standiford and I have shared patients where you stop these drugs because they feel so good, and then after 2 or 3 months they come back and say, oh, I don't feel so good. So there's no exit strategy perhaps except with IgE therapy. If someone is particularly very allergic and can't tolerate immunotherapy, and you stabilize them, they get immunotherapy, maybe there's a chance they could get well enough to get off that therapy. And so I think part of the hesitation in starting these therapies is we don't have a finite amount of time when we're going to use them. But for patients, they really are life-altering treatments.
Well, of course, the biggest problem is that if you don't have really good insurance,
right,
you get charged the whole retail price.
Right.
If the insurance company gets involved and they're aggressive prescription managers, they'll probably get a 40% discount.
Yeah, and also...
Which they don't share, of course.
Yeah, and also if you get denied twice or you're uninsured, a lot of the pharma companies will cover the drug for you. But it's a significant amount of work you have to do to get these things approved.
One last question. Mike?
So you described very good response to the biologic treatments.
Mm-hmm.
If a patient doesn't have as robust a response as you'd like to one,
Mm-hmm.
what is your experience as far as switching to another one?
I think you can switch even within class. So I've had patients who remained oral corticosteroid dependent on one drug, and I switched them to another drug and I managed to wean them off steroids. Or you have a partial response. You can switch between classes, you can switch within classes, and occasionally if someone was really, really sick and I gave them Xolair first, for example, and they had an improvement, but it's not a total improvement, I'll sometimes do dual biologic therapy, then you're really getting into it. In the future, we have some drugs like the TSLP drugs, if they prove to be successful, that will be higher up in the pathway. So maybe you'll think, well, if I go high up, I might be able to get an added improvement. And so I don't think switching within class is a bad idea. It's sort of like inhalers, right? You give someone Advair and they come back and say, it didn't do much for me. You sometimes will try a different inhaler and they like the drug better or it has better effects. And unfortunately, I can't off the top tease out who's going to be what I call hyper responder, the virtual, I'm cured, I have such little asthma, versus the I'm better versus I don't think it's working that well. It's hard to tease those patients apart at the beginning. With Xolair, you have to wait 4 or 6 months to really say yes or no. With the IL-5 drugs, you have to wait a month or two. I mean, if it's going to be a dramatic improvement, it's quick. The patients come back and they are much better. You can start weaning oral corticosteroids pretty quickly after the second dose.
Okay, thank you very much.
Thank you.